Welcome to Clinical Minute. Louisa is a 28-year-old woman, G1P0, who is 10 weeks pregnant. She is presenting to you, her primary care provider, complaining of migraine headaches. You'd previously diagnosed her with migraines without aura and prescribed 25 milligrams oral sumatriptan tablets. She stopped taking her medication as soon as she found out she was pregnant. You greet Louisa and ask her how she's been. After a couple of minutes of catching up, you ask how you can help her today. She says that she's been having bad migraines about once a week since she's been pregnant. She goes on to say that she's been trying to stick with acetaminophen, but it's not doing much of anything. As a result, she's been missing a lot of work recently. She asks, "Is there anything else I can take that's safe for the baby? And what about breastfeeding?" What do you tell Louisa? You know that 13% of the general U.S. population experiences migraines. However, among women ages 25 to 40, the prevalence is estimated at 25%. And among people seeking care from a primary care provider for recurrent episodic headaches, 90% have symptoms that warrant a diagnosis of migraine. Furthermore, you know that women are disproportionately affected by migraine, particularly during reproductive years. Among women migraineurs, 70% experience menstrual-related migraines, or migraines that occur with regularity just before and/or during menstruation, when estradiol levels decrease. You know that according to the ICHD-3, a migraine without aura is an episodic recurrent headache lasting 4 to 72 hours. It is a headache with at least two of the following pain qualities: unilateral location, pulsating quality, moderate to severe pain, and aggravation or avoidance of physical activity. Also, during the headache, the patient must experience at least one of the following: nausea, vomiting, or photophobia and phonophobia. Finally, the headaches must not be better accounted for by another ICHD-3 diagnosis. Migraine with aura may be diagnosed when a patient has two or more instances of migraine with one or more of the following fully reversible aura symptoms: visual symptoms such as bright lines, shapes, or objects; sensory symptoms including burning, pain, or paresthesia; speech or language symptoms from mild word-finding difficulty to dysphagia; motor symptoms such as weakness on one side of their body; brainstem symptoms including dysarthria, tinnitus, diplopia, or ataxia; or retinal symptoms, ocular migraine, monocular loss of vision. They must also have at least two of the following four characteristics: at least one aura symptom spreads gradually over 5 minutes or more, and two or more symptoms occur in succession. Each individual aura symptom lasts 5 to 60 minutes. At least one aura symptom is unilateral, and the aura is accompanied or followed within 60 minutes by headache. As with migraine without aura, migraine with aura is diagnosed when symptoms are not better accounted for by another ICHD-3 diagnosis and transient ischemic attack has been excluded. You know that during pregnancy, the only Category B medication to treat headaches is acetaminophen. However, Louisa has told you that acetaminophen isn't working for her. You know that triptans, the first-line treatment for migraines, are technically a Category C medication during pregnancy. However, you also know that several studies have shown no harmful effects to fetuses. A review of data from before 2001 found no evidence of sumatriptan teratogenicity. In a Norwegian mother and child cohort, 2.2% of 69,929 pregnant women used a triptan during pregnancy. There is no association between triptan use during pregnancy and congenital malformations compared to controls. Similarly, a prospective pregnancy registry in the U.S. and Canada found no sign of teratogenicity. Also, a Swedish study of more than 2,000 women found no increased risk of major or minor birth defects with sumatriptan use in the first trimester. You also remember learning at a conference that the sumatriptan nasal spray would be a logical first choice for treatment during pregnancy because it has been shown to result in a lower maternal serum concentration than with the 25 mg sumatriptan tablet. In addition, efficacy is not compromised in the event of gastric stasis or vomiting. As for breastfeeding, you know that virtually all drugs taken by the woman will be present to some extent in breast milk. With normal consumption of approximately 0.15 liters per kilogram per day of breast milk, the infant's relative dose can be expressed as a percentage of the maternal dose. An arbitrary cutoff of 10% has been accepted as a guide to the safe use of most drugs in lactation. For drugs with greater inherent toxicity, this cutoff does not apply, and breastfeeding would be contraindicated. You remember a table of the American Academy of Pediatrics ratings for drug use in pregnancy. Categories 1 to 3 have been shown to have harmful effects. Therefore, they are not compatible with breastfeeding. Category 7 is food and environmental agents. Most prescription medications fall into categories 4, 5, and 6, which are commonly referred to as concern, caution, and compatible. Triptans fall into category 6, usually compatible with breastfeeding. In rat studies, rizatriptan has been found to be concentrated in rat breast milk. However, sumatriptan and elatriptan have demonstrated low relative infant doses, suggesting that their use during lactation should not pose a substantial risk to the infant. As with all medications prescribed during lactation, the lowest effective dose is recommended. In answering Louisa's questions, you start by telling her that migraines sometimes get worse during the first trimester of pregnancy, but usually get better after that. You tell her that you can prescribe her a nasal spray version of the medication she'd been taking for her migraines before getting pregnant. When you see that Louisa has a worried look on her face, you say, "You look like you might have some concerns." She nods and asks if it's really safe to take such a powerful medicine during pregnancy. You reassure her that the medication you prescribed, sumatriptan, has not been shown to have any negative effects in pregnancy, and that you're also being extra cautious by prescribing the nasal spray, which shows up in lower concentrations in the mom's bloodstream than the tablets do. You go on to tell her that sumatriptan is also considered safe during breastfeeding. She'd be able to continue using the nasal spray as needed, or could switch back to the tablets if she finds that they're more effective for her. Louisa looks relieved. You explain use of the sumatriptan nasal spray. Like the tablets, it should be taken as soon after a migraine starts as possible. She will 1. Blow her nose gently, 2. Remove the protective cap from the sprayer, 3. Hold the sprayer between her fingers and thumb, 4. Use her other hand to block one nostril by pressing firmly on the side of her nose. 5. Put the tip of the sprayer into her other nostril as far as feels comfortable, about 1/2 inch. She'll keep her head upright and close her mouth. 6. Breathe in gently through her nose while pressing the plunger firmly with her thumb. 7. She'll keep her head level and remove the tip from her nose. 8. Breathe gently in through her nose and out through her mouth for 10 to 20 seconds. It is normal to feel liquid in your nose or the back of your throat. The sprayer only contains 1 dose of medication. After you have used it, throw it away in a trash can that is out of the reach of children and pets. You ask if she has any other questions. She says she doesn't. You tell her she is welcome to get in touch if she finds that she does have questions or if the medication isn't working for her. You write out the prescription for sumatriptan nasal spray and tell Louisa that you would like her prenatal care provider to know about the prescription. You ask if she is willing to give you contact information and sign a release of information so that you can contact her provider. She says, sure, gives you contact information, and signs the release of information form. Later that day, you inform her prenatal care provider about the prescription.